Welcome everyone. In this video we shall be talking about malignant hyperthermia and discuss all the important questions related to it. So moving on to the first question. Now, malignant hyperthermia is primarily caused by mutation in which receptor? So remember that it is due to a mutation in the ryanodine receptors, right? What happens? These ryanodine receptors are responsible for responsible for the release of calcium from the sarcoplasmic reticulum. It controls the release of calcium from sarcoplasmic reticulum, which is essential for muscle contraction. Now, as a result of the mutation, right, there is a mutation over here. Now, as a result of the mutation, there is uncontrolled release. There is uncontrolled release of calcium. Uncontrolled release of calcium, and this uncontrolled release of calcium would result in a sustained muscle contraction. And a state of hypermetabolism. ठीक. So the sustained muscle contraction first appears as masseter spasm, right? It starts as a masseter spasm and then it progresses to the entire body. ठीक है. Whereas if we talk about the state of hypermetabolism, this is associated with increased temperature, hyperthermia. Then we have lactic acidosis. What happens is that due to the sustained muscle contraction, the muscles are utilizing oxygen and finally resorting to the anaerobic pathway, leading to production of lactate. Okay. Then we also get increased carbon dioxide production, which is seen as increase in EtCO2 or end-tidal CO2. Okay. So this is everything that is happening in malignant hypothermia, and that is due to mutation in this ryanodine receptor. Okay. Nicotinic acetylcholine receptors are present in the neuromuscular junction, and there is no role in malignant hypothermia. Dihydropyridine receptor, although there is an interaction between these two, which is seen in excitation contraction coupling, but malignant hypothermia is not due to any problem in this excitation contraction coupling, and sodium channels is just way out of the box and option. Okay. So B should be our correct answer. Moving on to the next question. Which anesthetic is safest in a patient susceptible to malignant hypothermia? Remember that the safest volatile anesthetic that can be given is nitrous oxide. Remember that. Malignant hypothermia, there are certain precipitating agents, right? Malignant hypothermia is almost always secondary to some anesthetic drug, right? Number one is succinylcholine, which is a muscle relaxant. We have studied about succinylcholine in our video on muscle relaxants. Okay. And then we have volatile agents. Volatile agents like sevoflurane, like desflurane, like isoflurane, and halothane. These are the things that can trigger malignant hypothermia. But nitrous oxide, although it is a volatile agent, but it is not a triggering agent. Why? Because nitrous oxide is N2O. It's like not chemically capable enough to interact with the ryanodine receptors to trigger malignant hypothermia. Okay. Moving on to the next question. Earliest and the most sensitive indicator of malignant hypothermia during anesthesia is, it is without doubt rising end-tidal CO2. Okay. Remember that hyperthermia is a late sign. Whereas masseter spasm and tachycardia, both of them are early signs. And masseter spasm is the earliest clinical feature to be elicited, observed in the patient of malignant hypothermia. But the thing is that its sensitivity is very low, right? Most sensitive indicator, the question also asks us about the most sensitive indicator. The sensitivity of masseter spasm is very low. And if we talk about tachycardia, although it is a early finding in malignant hypothermia, but it is an extremely non-specific finding. Just with tachycardia, we cannot stamp a patient as malignant hypothermia, right? But with rising CO2, rising end-tidal CO2, yes, it is rather the earliest as well as the most sensitive indicator of malignant hypothermia. Okay, so answer should be D. Okay. Moving on to the next question. A 26-year-old man undergoes emergency surgery for a long bone fracture under general anesthesia, right? The induction is done with propofol and anesthesia is maintained with isoflurane. Shortly after induction, capnographic changes observed, which is shown in the image below. What is the most likely diagnosis? Now, this is the capnographic finding. Over here, the first thing that we need to see is the shape. The shape of the curve is maintained. But what do we see? This progressive rise. In the baseline. Is seen. Now, this characteristic thing where the shape of the curve is maintained and there is a progressive rise in the baseline is very much characteristic of malignant hyperthermia. Moreover, the anesthesia is maintained with isoflurane, which is a risk factor for malignant hyperthermia. Okay. So that's why our answer is malignant hyperthermia. Let's have a look into the other options. Bronchospasm. In bronchospasm, remember that in bronchospasm we get a shark fin pattern in capnography. What is the shark fin pattern? Right, it is something like this. The curve will be something like this. Right. This is characteristic of bronchospasm. It looks like shark fin, that's why. Inspiratory and expiratory valve malfunction. This is quite important, right? In inspiratory valve malfunction, we get a prolonged plateau. Right, that's why the curve will be something like this and this, right? It will be prolonged. Okay. But if we talk about expiratory valve malfunction, two things happen over here. First of all, we get a short curves, we get the short plateau. Right. Another important thing is that due to this expiratory valve malfunction, there would be CO2 accumulation. That's why the baseline will rise, but the thing is that we won't get a progressive rise. This would be something like this. Right. There would be a rise in baseline, but the rise in baseline is constant. There won't be a progressive rise like this. Okay. So progressive rise is characteristic of malignant hyperthermia, whereas a constant rise is characteristic of expiratory valve malfunction. Okay. The answer over here would be A. Moving on to the next question. Lab findings in malignant hyperthermia include hyperkalemia. Yes, we do get hyperkalemia. Why? Because of the sustained muscle contraction. There would be myocyte damage. Leading to rhabdomyolysis. Okay, and this rhabdomyolysis would result in release of the intracellular content, especially potassium, right, leading to hyperkalemia, and this can even trigger cardiac arrhythmias. Okay. Metabolic acidosis. Yes, we do get metabolic acidosis. This is secondary to the hypermetabolic state. This is due to the hypermetabolic state. As discussed, that the muscles are contracting, there is a hypermetabolic state, increased oxygen demand, right? The oxygen demand cannot be met, as a result of which the body sets itself up into an anaerobic environment, or rather it takes advantage of the anaerobic metabolism, leading to production of lactate, and this lactate results in lactic acidosis. That's why we get a high anion gap metabolic acidosis. Okay. Elevated creatine kinase. Yes, elevated creatine kinase is also characteristic. This is due to the myocyte injury or muscle injury. This is due to the muscle injury. Okay. Hypocalcemia. Now, remember that hypocalcemia is not seen, right? We have intracellular increase in calcium, but that is not due to transfer of calcium from extracellular environment to the intracellular environment. It is due to release of the stored calcium in the sarcoplasmic reticulum. Remember that the serum calcium is almost always normal in malignant hyperthermia. That's why hypocalcemia is not seen. Answer should be A, B and C. Option A should be our answer. Excuse me. Okay. Moving on to the next question. Conditions that can mimic malignant hyperthermia. Now, remember that malignant hyperthermia is characterized by muscle contraction, and a state of hypermetabolism, characterized by increased temperature, increased blood pressure, increased heart rate, right? Those things. Increased oxygen demand. Okay. So, if you have a look into the thyroid storm, yes, thyroid storm, there would be increased metabolism, there would be a state of hypermetabolism, there would be increased temperature, tachycardia, blood pressure, increased oxygen demand. So yes, it would mimic malignant hyperthermia. Neural malignant syndrome, yes. Neural malignant syndrome, we get muscle rigidity. We do get muscle rigidity. We have increased temperature. We have increased creatine kinase due to myocyte damage as well as seen, right? This is usually secondary to antipsychotic use. This is usually secondary to antipsychotic use. Okay. And we do get almost all the features similar to that of malignant hyperthermia, right? So this is a differential. Then sepsis, yes, sepsis is also a state of increased metabolism. Sepsis is also a state of increased metabolism. Similarly, pheochromocytoma crisis, yes, in pheochromocytoma crisis we have a sympathetic surge which would be responsible for increased heart rate, increased blood pressure, increased temperature, right? Everything. Excuse me. So all of them over here can mimic malignant hyperthermia. Okay. Moving on to the next question. The drug of choice. The drug of choice for malignant hyperthermia, without doubt, it is dantrolene or dantrolene sodium. Right. It is used at a dose of 2.5 milligram per kg per dose, and it can be repeated. And it can be repeated every 5 minutes up to a maximum dose of 10 milligram per kg. Okay. Another important thing regarding dantrolene is that the diluent is not NS. Diluent is distilled water. Diluent is distilled water. Okay. Bromocriptine is actually the drug of choice for neural malignant syndrome. Right. We shall be discussing about neural malignant syndrome in details when we talk about antipsychotic drugs. Diazepam, muscle relaxant sedatives, no role. Propranolol can manage the tachycardia component but not overall malignant hypothermia. Okay. The answer should be dantrolene. Moving on to the next question. The immediate management steps for malignant hypothermia include stop triggering agent. Yes, this is rather the first step. This is rather the first step that we should do, right? We should stop the triggering agents. Then 100% oxygen. Yes, we need to use high flow. We need to use high flow 100% oxygen. This is to manage the increased oxygen demand due to the increased oxygen demand that the body is in a state of hypermetabolism. So we need to provide the oxygen for that so that the body does not resort to anaerobic metabolism, right? And moreover, this high flow oxygen can also cause washout of the volatile anesthetic agent, right? Okay. Active cooling, yes, active cooling because of the to counter the hyperthermia component. Active cooling can be done with ice packs. With cold IV fluid. Moreover, gastric or bladder lavage with cold fluids. Lavage with cold fluids. Okay. Calcium gluconate. Now see, calcium gluconate is usually not used. It is usually not used, right? There's one indication if there is symptomatic except in symptomatic hyperkalemia. In symptomatic hyperkalemia, we have to use calcium gluconate because symptomatic hyperkalemia, the patient can die, right? We need to stabilize the heart with calcium gluconate. Okay, so calcium gluconate's indication in malignant hyperthermia only when it is complicated with a symptomatic hyperkalemia. But over here, the patient presents the question asks us about the immediate management. So in immediate management, we won't be using calcium gluconate. Okay. The only indication to use calcium gluconate is the symptomatic hyperkalemia and malignant hyperthermia. Okay. So the answer should be A, B and C. Okay. Moving on to the next question. Complications of malignant hyperthermia include rhabdomyolysis. Yes, this is due to the sustained muscle contraction. Leading to myocyte damage. Acute renal failure. Yes, now this is due to the secondary. This is secondary to the myoglobinuria. Right, due to again the muscle damage. DIC. Yes, we can also see DIC because this DIC can be precipitated. Due to hyperthermia or the metabolic acidosis. Metabolic acidosis or hyperthermia can trigger DIC in a patient. Okay. Hypoglycemia, no, we do not get hypoglycemia. This is a state of hypermetabolism. Increased metabolism would result in hyperglycememia, not hypoglycemia, right? Now one might think that due to increased metabolism, increased utilization, glucose may be utilized. No, your glycogen stores will be depleted. Gluconeogenesis pathway would be activated, but it would result in increased glucose in our blood. Okay. So the answer should be A, B and C. Okay. Moving on to the next question. The most common cause of death in untreated malignant hypothermia. It is without doubt cardiac arrhythmias, and these cardiac arrhythmias is due to hyperkalemia, right? And even metabolic acidosis can add up to it, right? The causes due to hyperkalemia, and metabolic acidosis can add to the damage, right? Okay, so cardiac arrhythmias is the most common cause of death. Although we can get these three causes, but the most common cause being cardiac arrhythmia. I'm so sorry, right? Moving on to the next question. Gold standard test for diagnosing malignant hyperthermia susceptibility. So in order to diagnose susceptibility, the gold standard test is caffeine or halogen contracture test. Right, this is done using a muscle biopsy. The muscle is right. We use caffeine or halogen on that biopsy specimen, and then we evaluate for the susceptibility. Okay. This genetic testing can be used as a screening test. For family members. You all know that this is a genetic disorder, right? So it can be used as a screening test for family members, but not for diagnosing susceptibility, right? Because the sensitivity for genetic test is very low. The caffeine or halogen contracture test is a gold standard. Muscle biopsy, histology has no role in diagnosing susceptibility, and serum creatine kinase level, these are non-specific for susceptibility, rather for acute episode. These are acute episode marker. This is an acute episode marker, right? If there is an acute episode of malignant hyperthermia, there would be myocyte damage and release of creatine kinase, and then it would rise. Okay, but just susceptibility can't be diagnosed with CK levels. Okay, so the answer should be B. Moving on to the next question. Now, conditions associated with increased malignant hyperthermia risk. Now, central cord disease. Yes, central cord disease is actually a congenital myopathy. So it does increase the risk, right? Similarly, King-Denborough syndrome, right? King-Denborough syndrome, again a named myopathy. It is also a genetic myopathy. Okay. It also increases the risk of malignant hypothermia. And if we talk about myasthenia gravis, no, it does not, because myasthenia gravis, the problem is an acetylcholine receptor, which has no relation with malignant hypothermia. Okay. Now, if we talk about this Duchenne's muscular dystrophy, right? Marrow mentions that Duchenne's muscular dystrophy increases the risk of malignant hypothermia, but it does not. Okay. It does not increase the risk of malignant hypothermia. It rather increases the risk of something called malignant hyperthermia-like syndrome. Malignant hyperthermia-like syndrome, not MH per se. Okay. We would get rhabdomyolysis. We would get rhabdomyolysis. Yes. If someone asks you about whether Duchenne's muscular dystrophy increases the risk of rhabdomyolysis when a patient is exposed to volatile anesthetic, yes, it does increase the risk of rhabdomyolysis. It does increase the risk of hyperkalemia. It does increase the risk of cardiac arrhythmias, but it does not increase the risk of malignant hyperthermia. Okay, the exact procedure, the exact physiological, pathological changes that occur in a malignant hyperthermia is not seen in a patient with Duchenne's muscular dystrophy, right? That's why it increases the risk of malignant hyperthermia-like syndrome and not malignant hyperthermia. Okay, that's why B is not an answer. So our answer should be A and C. Okay. So with this, we come to the end of our discussion on malignant hyperthermia. This is a very important topic for NEET PG especially. So if you like this video, consider subscribing to my channel, and thank you for watching.